people on treatment has reduced substantially was because after release from prisons, when the treatment was available, many of them traveled to their rural areas where the treatment capacity is zero and there are no any infrastructure for providing treatment and opioid agonist maintenance treatment. Also, the situation with treatment centers is desperate because many of them were created with funding from external sources and they are not integrated into the health systems and social care systems. And that's why when the funding has stopped, in fact, these settings, they were functioning, and still some of them are functioning just on enthusiasm of workers, because they don't receive salaries anymore. But the situation is very desperate. At the same time, there were several big fundraising events for Afghanistan, and already some money becomes available for WHO country office. And again, I think this is also a result of the situation as well as the assessment of the mission, that some of this money would be devoted to provision of treatment of people with drug use disorders. At the same time, it's definitely the scope of the problem and the resources which are available right now are not at all equal. So there's still a huge problem, but we pay attention to that. We do what we can. And of course, the major burden is on our regional office and country office, but the work is ongoing. And we would be happy to report in future on what has been specifically done as a result of all these activities. But some good progress has been made, even with the funds available to these issues. And also, I think that was the first time when substance use and drug use related issues were so prominent, when in fact the whole mission was initially planned as assessing the mental health in emergencies. But it's clear that drug use and people who use drugs are in a very difficult situation right now, and the treatment is interrupted in many settings, and something has to be done. And we know, in fact, what might be the first steps. Thank you.
Great, thank you. Hopefully that situation will get better. So next year we can get some better information from Afghanistan, from WHO and other institutions. So let's try again with Christina. Christina, can you? But we don't hear you. At least I don't hear you. No, unfortunately not. But I can ask the question, so we can still have this question on the agenda. So sorry, Christina, but you know, we all have sometimes problems with voice and technical issues. So the question by Christina from Christina is that, has the WHO monitored since December 2021 global trends showing whether the liberalization of cannabis and related products is doing more harm than good? What does WHO plan ahead in light of these findings? Please.
Vladimir, do you start or shall I start? You are muted.
I thought that you will start, Gilles.
Okay.
Yeah.
So with respect to the, the expert committee on drug dependence related work, it is not within the ECDD mandate to monitor the use of controlled substances at country level, including cannabis. So it's rather monitoring of the convention continues to be within the mandate of INCB. In addition, as it is mentioned in the question, the ECDD has not recommended for liberalization of cannabis, but rather recommendation of the 41st ECDD was for cannabis to remain in Schedule 1 of the 1961 Convention. and it is up to the countries to implement the conventions according to their national context. I'll stop here. Vladimir, my colleague, may have to add. Thank you.
Well, just to add that within UN system, the situation with monitoring drug use, prevalence of drug use is with the UNODC when they have a special program and they publish yearly world drug reports. At the same time, WHO is concerned with health consequences, health impact of any substance use. And as we are working on the second edition of our publication on health and social consequences of non-medical cannabis use, we also looked at the epidemiological data in those jurisdictions which liberalized significantly regulations related to cannabis. And of course, the picture is not very straightforward, because what we see from the published studies and from the epidemiological research done so far, then that in younger generation, among young people, the use of cannabis, even in jurisdictions when it's fully legalized for recreational use, continues to going down, whereas some increase is being recorded in middle-aged populations. So the picture is quite complicated, and I think it's too early to make very decisive or conclusions which are fully based on available evidence. So that's why I think we, the international research community, have to continue to monitor the situation. I'm not sure if UNODC colleagues in Vienna have any particular activities on monitoring the situation, but in WHO Secretariat, we simply have no sufficient capacity to do that, though we definitely monitor the situation from the published literature in terms of impact of cannabis consumption on health. Thank you. Over.
Great, thank you. Let's continue with questions. We have another question from, it's from Turkish Green Crescent Society. The fifth question, so I hope somebody from Turkish Green Crescent is with us today. So please, the floor is yours. We don't see anybody. No, then I will read the question. So in recent years, we have observed that youth is particularly susceptible to increased level of stress when they are already dealing with pressure to high academic achievement. Sadly, this also causes some students to reach out for smart drugs, or in other words, the non-medical use of prescription stimulants. What are the most cost-effective protective factors that member states can design programs and policies on, focusing on youth, that WHO can recommend? Thank you.
Well, I'll try to respond to this question. First of all, thank you for raising this issue, because of course the use of prescription drugs is a particular area when very special focus is needed. At the same time, I should say that WHO has not made any cost effectiveness analysis of interventions that can be focused specifically on the use of stimulants by youth in the context as presented in the question. So that's why I think there is overall guidance on prevention of use of psychoactive drugs among young people and adolescents. I want to refer to the chapter on prevention of non-medical use of prescription drugs in the International Standards on Prevention of Drug Use that was published by WHO and and UNODC. It was largely UNODC work, but we contributed substantially with methodological approaches and with the finalization of all the main messages. But still, it's quite broad. It's I wouldn't say that it responds to the very specific question that was posed. Also, there is a very broad initiative of WHO on accelerated action for the health of adolescents, so-called AHA initiative, which provides general recommendations for countries to protect health of adolescents, of young people, with very different approaches. And I would say that the specific focused approaches, prevention approaches on drugs or on alcohol or on tobacco, the evidence is more to support broader health promotion activities among young people, and rather to address all the issues related to drugs, alcohol, and nicotine across different policy and program measures, rather than have very specific ones to be developed, because some of them are quite costly. But anyway, I would refer to this publication. At the same time, I think this is a gap in WHO guidance on prevention and management of prescription, non-medical use of prescription medicines. I think that it's good to see that this gap has been picked up. We will see how we can address it in the future. Thank you.
Great, thank you. Thanks for mentioning international standards, because this is really a good guide for all future evidence-based prevention interventions. And we know from our experience that in evidence-based prevention programs, they actually don't focus so much on substances or risk behaviors as such, but most on risk and protective factors. So this is the case behind evidence-based prevention programs. So this should be the focus. It doesn't matter what are the drugs or risk behaviors behind. And that's thank you very much for mentioning this valuable publication published by UNODC and WHO. So let's move back to the second question, because I see we have a colleague from IDPC with us. So Adria, please ask the question, the second one.
Yes, thank you, Mete, and I apologize for the delay in joining the meeting. And also thank you to everyone and to the WHO colleagues in particular for your time and availability for this important dialogue. So our question is the following. Globally, the rates of drug overdose deaths continue to rise. There is clear evidence that harm reduction interventions such as drug checking services and supervised injection facilities can help prevent many of these deaths. What is the WHO's position on these critical life-saving interventions, given that there is a need for robust technical guidance on how best to design and deliver these services? Thank you very much.
Thanks. Thank you very much, Adria, to raise this question. It's a question that actually often comes to us. Just to be upfront, WHO does not have an official recommendation with regard to these two options. We do, of course, recommend harm reduction and have defined harm reduction as a set of interventions that include the nine that we agreed some time ago with other UN agencies, and we've actually added naloxone, community distribution of naloxone to the package. So the reason that we do not have recommendations for these two interventions is twofold. One is that we haven't had the opportunity to really go into doing systematic reviews on these interventions, because at the time that we were first interested in looking into this, the evidence was quite limited, and we cannot make recommendations with limited evidence, for example, only coming from one country, or only in high income settings where these interventions occur. So what we have done is that in various guidance documents, we have narrative like describing that countries that have implemented these interventions show very good outcomes. So we say things like that. And the second reason why we haven't really made a lot of effort into looking into this is that the current state of implementation of harm reduction is so appallingly low, with this limited package as defined, as I said, as needle and syringe programs or access to safe injecting equipment, opioid agonist maintenance therapy, as well as other evidence-based treatment options for other types of substance use, and naloxone distribution. We know that less than 1% of people who inject drugs have access to those services. So we also feel that by adding more expensive, more complex interventions, such as these two that you propose, could probably backfire in a lot of countries where we're trying to just get the minimum of these interventions implemented. So these are the two main reasons. Still lack of evidence for not having looked systematically, doing a systematic review on these. At the same time, also strategically not trying to complicate the package for especially low-income countries, because of course WHO tends to focus the guidance and the norms and standards for low and middle-income countries to make things more complicated than they are. Thank you. I hope that answers your question.
Thank you very much for your answer. Let's proceed to next question by students for sensible drug policy. Benedicta is with us to ask this question. Please, Benedicta, the floor is yours.
Thank you very much. In the revised 2018 UNODC International Standards on Drug Use Prevention and the Chapter 1 of the International Narcotic Control Board INCB Report 2019, several evidence-based interventions strategies are recommended in order to protect vulnerable people from the adversities of early problematic drug use and substance use disorder. The crucial role of education and healthy environments for the development of a young person is pronounced. Multiple studies suggest that engaging in several leisure activities improves young people's general mental health and well-being, and also reduces problematic substance use from an early age. However, it is emphasized in paragraph 71 of the INCB report 2019 that there is a lack of substantive evidence in regards to the effectiveness of leisure activities such as sports clubs, as well as peer education and support at entertainment venues. Additionally, in the conjoint 2018 UNODC and WHO International Standards on Drug Use Prevention, the lack of high quality research conducted on these materials is identified as well. So the question is the WHO planning to conduct or incentivizing research into the effectiveness of peer education and support, as well as leisure activities such as sports club for young people, with regards to improvement of the overall mental health and well-being of young people, as well as mitigating problematic drug use and its risk?
Well, I'll try to answer this question, though this question is a very complex one because leisure activities is not difficult to define in a way that can be used in research designs with the outcomes that can be documented due to these specific activities, when they are, again, they need to be very well defined and to control for factors which may influence the outcomes of this research is very difficult. That is why we have inconclusive evidence of impact of, for example, sport activities on the use of psychoactive substances. And sometimes research that was undertaken comes to different results. To some extent, it can be linked to subcultures, youth subcultures, which can have very different attitudes towards substance use, like, for example, use of steroids in sport clubs. So that's why for WHO to embark on this type of research would be a matter of prioritization of our activities in the situation when our resources are limited and we need to address the most pertinent issues. At the same time, our guidance, I think, as well as the guidelines provided in international standards on prevention, is that communities and families definitely play an important role in the prevention of substance use, but also some broader policy measures related to availability, related to, again, balance of risk and protective factors, related to the possibilities to get access to services when it's needed. So all this would have a play, but we don't have currently any activities, research activities, and we don't plan any research activities to explore specifically the questions of leisure activity or sport activities and their impact on mental health or on substance use, specifically because of the complexity of such research, and not very clear what would be the findings. So we would like to see that this research is being undertaken by academic institutions, by research groups, and we would be happily use the outcomes of this research in our work. Thank you. Over.
Thank you very much. Let's proceed with the next question. Asked by International Association for Hospice and Palliative Care from the United States. I see Catherine is with us, so please, Catherine, the floor is yours.
Thanks, Matej, and thanks, WHO, for this dialogue. So my question is, to prevent the spread of the US or North American opioid crisis, the Stanford Lancet Commission on the North American Opioid Crisis report, which was launched on February 5th this year, recommended that, quote, the World Health Organization, with support of donor organizations, should coordinate delivery of generic morphine to hospitals and hospices in low-income countries. This action will require the support of the International Narcotics Control Board, which oversees the UN Conventions on Narcotic Drugs and licenses and regulates licit opioid production, close quote. Would the WHO be prepared, in principle at least, to implement such a recommendation, given the historic imbalanced application of the drug control treaties that has resulted in more than 70% of the world lacking access to opioid medicines for pain relief and palliative care? And I'd just like to say I asked the same question of the INCB president, and she said, yes, they would support that. So I'm really looking forward to hearing your response. Thank you. I'll take myself up the air.
So thank you, Catherine and colleagues, for this question. And we of course take the recommendations of the Stanford Commission, Lancet Commission on opioids very seriously, and we will hopefully will be engaging with the Commission to discuss how is this recommendation implementable. As you can imagine, it's a huge task for supplying hospitals, hospices in low and middle income countries, but we'll be happy to help. Together, I think this implies, of course, mobilizing resources, because at the moment, to my knowledge, there are no financial resources available to implement such a project. Number one. Number two, we'll need also to engage with the existing platforms that are procuring medicines and in bulk and pool procuring medicines. And there are a few of those platforms in the world, because WHO prime mandate is not to buy or to supply medicines. But we do work with those platforms, and we can also identify a strategy for engaging those platforms, and also reflect with the Lancet Commission how to make this process sustainable. Because I think, and this will be the most complicated and difficult task, is to make sure that if this recommendation is implemented, it is sustained. It is sustainable in time. So therefore, there are a number of important issues that need to be discussed with the Lancet Commission to make sure that this recommendation is implemented successfully. And of course, we would like to take our part in those discussions. Over.
Thank you very much.
Thank you.
Let's proceed to the next question by Transnational Institute. Martin is here with us, so please, Martin, the floor is yours.
Yeah, thanks, and thanks to the NGO committee and the WHO to continue this important tradition of the dialogues. So my question relates to the limits of the CND discretion under the 1971 Convention for making scheduling decisions and based on WHO recommendations. So in UNODC's brochure on scheduling procedures under the International Drug Control Conventions, they state that, and I quote, under the 71 Convention, the Commission may decide, even contrary to the recommendation of WHO, to place or not place a substance under international control or to remove it from international control, end quote. While there is greater discretion under the 71 Convention compared to the single convention, UNODC's assertion that the CND is authorized to add a substance to any of the 1971 schedules contrary to a WHO recommendation not to place it under international control seriously undermines the WHO treaty mandate and contradicts the position taken in the commentary to the 71 Convention. Please, can you clarify WHO position on this matter? Thank you.
So thank you, Martin, and thank you for this important question. I think we had started this discussion a few months ago. Unfortunately, we haven't been able to move forward, and so therefore, thank you to bring it again on the table. It is, of course, of great importance for the role of WHO and the ECD. Of course, we would not like the mandate of WHO ECDD to be restrained by any statement or any strategy that goes beyond the convention and so on. It's a very complex issue for which I don't have a clear WHO position today. But indeed, if you remember, this came to the table a few years ago when we were discussing a substance also, and we did a lot of exploring with the legal colleagues and counterparts and so on. But I think it's important that we continue to reflect on this issue, because this problem may come back again in the future. And so what I suggest is that I have engaged with some colleagues here, including our legal department. I don't have yet an answer to you for you today, but definitely we'll be interested to continue this discussion offline. And thank you for your help and thank you for your concern, because indeed it can be a matter of very serious concern. So I will continue to update this group and Martin on the progress that we make on this specific issue. As I said, it's very complex and it requires specific advice and expertise within house, which I didn't get so far. Thank you.
Thank you very much for your answer. Because Zara and Oriol are not with us today, we will skip those two questions, but we can still arrange, they can get answers and we all can get answers to those questions later on. So we will continue with the question 11 by Veterans Action Council. So Etienne is with us. So Etienne, the floor is yours.
Good afternoon. Thank you for selecting the Veterans Action Council's questions respectfully. Our cannabis reform movement strongly supports the WHO ECDD's process and deeply appreciates the strong evidence-based stand taken on ketamine, tramadol, CBD, cannabis, and kratom. How can the NGOs now work with the WHO to help ensure patient access throughout the world to cannabis and other plants used in traditional medicines? Thank you.
So I will attempt to answer this question also, and thank you again for those questions and for your interest and support to the work of the Expert Committee on Drug Dependence. We are very appreciative of that. Your support is very important. So the division, our division on access to medicines and health products is, as a core function, is involved in the development of norms and standards in the provision. So we are involved in norms and standards, but also we are involved in the provision of specialized technical assistance and expertise to improve access to all medicines and health products. And when I speak about medicines and health products, I speak about the finished product, and including controlled medicines, for example, for the management of pain, for the management of neurological and mental health conditions, and including also cannabis-based medicines like Epidiolex and other finished product and medicine. So in this respect, I think we are engaged through the normative work, but also to the technical support that we provide to country to improve, to address the barriers to supply of medicines, including, as I said, controlled medicines and including cannabis-based medicines, where our division is not comfortable and is not involved simply because of an issue of expertise. I think we may not be involved, particularly in the supply of plants. We are not involved in the supply of plants and procurement of plants, because this involves a different set of norms and good practices, for example, for their cultivation, for their procurement, and for the supply in countries. So unfortunately, our specific division do not have the expertise and the skills to really engage in the procurement, supply of, and distribution of plants. But definitely we can explore who else in the organization is involved in that, in particular colleagues dealing with the traditional medicine. Over.
Very much. We'll continue with question by Youth Rice from Hungary. Patrick is with us. So Patrick, please, the floor is yours. Patrick, are you with us? No? Then we will continue with the question by Fields of Green for All, MPC. So from South Africa, Myrtle, are you with us? Great.
Hello, yes, I'm with you.
Thank you.
And thank you very much for taking our question from South Africa. My question is similar, but somewhat more nuanced than Etienne's previous question. So it's fortuitous that mine follows his. How does the WHO intend to address the tensions that exist between the WHO recommendations for cannabis medicine as implemented by the CND and the reality of cannabis used as a traditional medicine throughout most of the developing world? Thank you.
Thank you for this question. And again, I will attempt to answer the question, but maybe the answer may not match the expectation of the person who has posed this question, and we can, of course, continue the discussion offline. So the traditional use for medical purpose should be governed by the laws of the country regarding medicinal use of cannabis. The ECDD issues recommendation for international scheduling and does not monitor their implementation in countries, including for the use of cannabis as a traditional medicine. This is again within the mandate of INCB to ensure the availability of substances in the schedules for medical use where necessary, while minimizing their diversion and harms due to non-medical use. Over, thank you.
Thank you very much. And the 15th question is from Mozambique, from organization REAUD. So, sorry for pronouncing. I have very small letters here on the paper, so that's the reason. So, Luis, are you with us to ask the question? No? Then probably it's the best solution, because we still have time, that I read the question. How can WHO support the development of harm reduction guidelines and rehabilitation centers for people who use drugs? So thanks for answer.
Yes.
We don't hear you well.
You don't hear me either?
Well, Annette, can you start? We can't hear you well, so.
Can you hear me now?
Something is wrong, so, yeah.
Yeah, let's do that, because I want to, you cannot hear me.
We can hear, but very, very low level, so if you.
Okay, so I just want to say that given that this question comes from Mozambique, that we actually, WHO has supported Mozambique in development of harm reduction guidelines and implementation plan 2019-2020. And of course, we're always happy to support countries, provide technical support to countries. Sometimes we're provide support through consultant to write the guidelines. So absolutely, we're there to provide technical support. Rehabilitation centers, I don't know, maybe you want to say something about it here?
Well, I can probably, because I think we can't hear you, Annette, but I will talk about rehabilitation centers. And this is this requests for WHO to support development of rehabilitation centers is quite common, because this is an issue almost in every country, what to do with sometimes with people who need more time for, and who wants to be engaged in treatment programs and rehabilitation programs, which sometimes requires many months of this type of engagement. So in WHO, our priority has been always on integration of interventions at primary health care and emphasizing the role of primary health care and interventions which can help and can cover by effective interventions more people to achieve more benefits for public health, for health of the populations, because populations' health is in the focus of activities of the World Health Organization. At the same time, it's also well acknowledged that some individuals may require this type of treatment and rehabilitation, which would require more time. What WHO provides? WHO does not fund these treatment centers or any other treatment centers, but WHO provides normative guidance, and we addressed the rehabilitation centers and long-term treatment for drug use disorders in the international standards for the treatment of drug use disorders. We provide technical support to improve quality of different treatment programs. We help countries to assess the treatment system capacity, which may involve and should involve rehabilitation centers, but at the same time, on the conditions that treatment in these rehabilitation centers is based on evidence and in full respect of ethical principles. So this, again, this kind of guidance is provided in WHO documents, but at the same time, I should say that though it's understandable that rehabilitation centers may be needed, it's for countries to decide how much of public health funds would be allocated to that. Many of these centers function as private centers, which raise the question of equity and accessibility of the centers for people with limited resources. So there, and these issues again is in the focus, are in the focus of WHO, because the equity in health services is an important issue for WHO. But that's probably would be my response to how WHO support the development of rehabilitation centers for people who use drugs. We cannot support them directly financially, though WHO advocate for example, for philanthropic organizations or other foundations to channel funds into the health services, with the focus again on those which can bring public health benefits with the same level of investment. Okay, thank you. Over.
Okay, thank you very much. We are running out of time for this informal dialogue. We have not cleared all questions because some are still remained unanswered. However, WHO promised us to provide all answers in writing after this session. So also those who are not asked or answered will come to our emails, and we'll see the answers later on. So thank you all for participation and for very valuable answers. Any final remarks or thoughts by WHO or somebody from Vienna NGO committee members? No? Then I would like to thank you all for participation again, and hope to see you soon at some other occasion, if possible in person. Thank you and goodbye.
Thank you. Bye-bye.